I'd like to move now to our inherited NETS portion of the program. And to introduce our speaker, I'm going to introduce Amy Powell. She is the president of the Paratroopers Association. Please welcome Amy Powell.
Good afternoon. I'd like to thank everybody for coming and say hello on behalf of the FIO Paratroopers. To tell you just briefly about our organization, we are a patient advocacy group that focuses on patients and family members of patients with pheochromocytoma and paraganglioma, and you can probably see why we abbreviate that now. I have good news, bad news, and great news, and you're going to get it in that order. The good news is that the Paratroopers are sponsoring a reception immediately following today's events outside. We'll have food, and you'll also have the rare opportunity to converse one-on-one with some of the presenters from today. The bad news is that Dr. Karen Adams had to cancel her presentation today for personal reasons, but the great news is that we found a really good replacement in Dr. Justin Annis. He's an associate professor of medicine at Stanford University and also has a special interest in inherited NETS syndromes and genetics. And so I think without further ado, I'd like to introduce Dr. Annis.
Thank you, Amy. It's really a pleasure to be here. I had suspicions that Amy intentionally delayed telling me till the last minute that I was going to sub in because she knows how anxious I get about public speaking, and this was going to ease my sleep for a little while. So what I'd like to do today is talk to you a little bit about inherited neuroendocrine tumor syndromes, and then particularly I'm going to try to talk about it from the perspective of you guys, of whether or not you ask yourself, is it possible that I have a hereditary condition, and what sort of simple questions you might think about. So I'll start by saying that I'm from Stanford, and I'm part of our neuroendocrine tumor syndrome there. Specifically, I do the hereditary neuroendocrine tumor genetics, so that tends to be a lot of the familial syndromes pre-symptomatically. That means before anyone develops anything, making sure family members are followed and get appropriate testing. And then I spend the majority of my time actually as a basic science researcher trying to model neuroendocrine tumor disease. And along those lines, I wanted to say that I went to my first NetRF research meeting this year, and it was tremendous. It was really great to have one of those moments where you don't feel isolated and you don't feel alone, that there's others like you. In fact, Joe Zhao, one of the awardees, happened to be the postdoc with the bench next to me several years ago, so that was great to see him again. Okay, so maybe the best place to start is with some simple definitions so that we're all using the same word. So a tumor in itself is not necessarily a bad thing, and it's not desirable necessarily, but it is an excess growth of a single cell. So tumors arise from a single cell. So that's called they're considered to be clonal. Initially, tumors are benign. That is, they acquire the ability to divide, but typically they stay in place. So if you catch a tumor early, it's usually in this benign state where the tumor doesn't yet know how to move. It just knows how to replicate. Over time, as there's delay, there becomes more diversity among the population, and some cells start figuring out how to move from one location to another. And then that's when we call it malignant or cancer. And then, since I'm talking about genetics, what a gene is the instructions that's located within the DNA on how to make a specific protein. So when we talk about a gene, we're talking about a specific protein that's, the instructions are in your DNA. Mutations themselves does not imply good or bad, it just implies rare. So mutations are changes in DNA that occur in less than 1% of the population. Every generation, about 100 mutations are passed from parent to child. Not all of them have any impact. Most of them, in fact, don't. And then mutations will also occur throughout life in cells. And those are, we'll talk about a little bit later. And then autosomal dominant is when you inherit, so you inherit your genes from your mom and your dad. So you have 2 copies of every gene. When you have an autosomal dominant condition, that means you inherited 1 copy that's changed, and that gives you a predisposition. That means it makes it more likely that you would develop a tumor. So that is, you have one normal copy still and one that's changed. Okay, so what happens with hereditary tumors? This is shown here on the left. This is for the hereditary neuroendocrine tumor syndromes. They're almost all autosomal dominant, like I'm showing here. Is that you're born with one change. In most conditions, this occurs because you had it in your family, or in your mother or your father. In a low percentage of cases, there's something called de novo. So the new mutation arises within you, and no prior family member actually had a tumor. So you, I lost the mouse. Oh, there. Most cells are totally fine with just one backup copy, and they just go about their business without any tumor formation. And then at some point in your life, a cell might acquire a second mutation. We call that a second hit. And so you need that second hit in order to actually develop a tumor. And so that sort of answers our question about why does it take so long? Why aren't I born with the tumors? And it's because over the course of your life, that second hit has to sort of randomly happen and remove the backup copy of the gene. And so once that happens, that cell will acquire the ability to divide, and then over time, the ability to spread if it's left in place. A different scenario is when you're not born with a genetic mutation, but over the course of your life, you develop a single hit and then a second unfortunate hit. This would be, these are somatic mutations, and so these are not inherited. And we'll get into those a little bit later, but this is how we think about genetic versus somatic disease. And genetic disease tends to be younger because you're starting off with one mutation already, whereas in the other case, you need to have two. Okay, I'm going to skip that. So then the next question is, well, why should I bother doing genetic testing? And there are a variety of different answers to this, but the main ones are because it gives us information about what to expect in you. So if we know you have a genetic condition, we have an idea of what might come next, where to look, what your risks of recurrence are, and hopefully eventually what treatments might be good for you. And it's very important for informing family members. Who else might be at risk? And who can we say, you know what, this is in your family, but you don't have to worry about it. So most of the conditions I'm going to talk about, genetic testing is recommended by professional societies. I'll specify when we're unsure and I'm sort of introducing new data. In most cases, we think that genetic testing will be of benefit. That means you'll personally benefit or your families will benefit from the genetic testing, and that's why it's recommended. But in almost all cases, we don't have an answer about what's the best way forward. So how do we take this information and give you the best possible treatment? We don't know that. We know how to try our best. And we think it's better than not knowing if you have the genetic mutation. Okay, so MEN1, like I said, is an autosomal dominant condition. I'm going to go through the different conditions which are related to neuroendocrine tumor syndromes. And there are a variety of features that are the sort of the cardinal features of MEN1, and that includes parathyroid adenomas or parathyroid tumors. These occur in about 98% of people over their life. So this is a pretty sensitive way of figuring out whether or not someone has MEN1. Unfortunately, it can take many, many years. So just because you're 40 and don't have it doesn't mean that you don't have MEN1. This could occur very late in life. Also, there are pancreatic neuroendocrine tumors as well as gastrinomas. And then pituitary adenomas are the other sort of third cardinal feature. And then there's some rare features of the disease. So now, as an individual who says, okay, I have a pancreatic neuroendocrine tumor, do I have MEN1? Or should I be tested? Or what's the likelihood that I have MEN1? And so here's a chart sort of going through, well, if you have these different features, what's the chance that you actually have an MEN1 mutation? And so it's given if you have no family history or if you do have a family history. So if you have all three mutations, that means a parathyroid, a pituitary, or a pancreatic neuroendocrine tumor, and no family history, there's only about a 70% chance. Still high, but 70%. That means 30% won't. If you have a family history, it's quite high. But then as you go down the list and now you say, oh, I only have 2 tumors, your percentage drops to about 23%, still stays high at 69 if you have a family history. But then for most of us, so if you just have one feature, the chances of having MEN are very low unless you have a family history. So there are a variety of other mutations that can look like MEN1. These are very uncommon, but I want to mention that just because you're MEN1 negative, meaning you have normal MEN1 testing, it doesn't exclude the possibility of there being another cause. And then another important note, now that tumors are getting more and more genetic testing, you'll frequently find an MEN1 mutation in the tumor itself. That's about 40% of pancreatic neuroendocrine tumors. That doesn't mean that it's in your germline, which means that if it's not in your eggs or your sperm, that is much less frequent. So that's 40% in the tumor, but that doesn't mean that it's going to be passed along through your children. But if you do have a mutation in your tumor that's MEN1, an MEN1 mutation, you should be considered for genetic testing for a germline mutation. Okay, I'm going to skip over management because we're short on time today. And then there are some rare neuroendocrine tumor syndromes. Again, in the interest of time, I'm going to put them up and mention them. Von Hippel-Lindau and neurofibromatosis. These are relatively rare causes of neuroendocrine tumors, of pancreatic neuroendocrine tumors. They're more closely associated with pheochromocytomas. Okay, and then this is something which is leaving us in sort of a new position, and we're not really sure what this means. So recently, there was a fairly large population of tumors, pancreatic neuroendocrine tumors, that were looked at, and this group found a fairly high level of germline mutations. In fact, these are found about 17% of the patients had a mutation in one of these genes, and they didn't have a family history. So this has put us into a new place where we think if you have isolated pancreatic neuroendocrine tumor, there is some possibility of a genetic cause. This is new information, and we're not sure how to integrate it into care, but I'm giving you what's up to date. The other sort of another controversial area is that small intestinal carcinoid has been associated with an IPMK specific gene. This hasn't been readily replicated by other groups, but at least it's out there as possibly a cause for individuals who have multiple family members with small intestinal carcinoid, or they have disease at multiple sites at once. Again, this is potential, not among the group of recommended genetic testing at this point. Okay, and then there's medullary thyroid cancers, which is associated with a condition called MEN2, a related condition, multiple endocrine neoplasia type 2. And this typically comes in 3 varieties, which is that medullary thyroid cancer alone, or you can have medullary thyroid cancer with pheochromocytoma and parathyroid adenomas. And then there's also another variety where you also have some physical feature changes. Earlier, there was discussion about what's the youngest age that someone could have a neuroendocrine tumor. And if you include RET within that, that's virtually from the time of birth. So these children, if they have the most aggressive form of the condition, will have surgery within their first year to preemptively remove their thyroid. My main point with MEN2 is that if you have a medullary thyroid tumor or a medullary thyroid cancer, so this is not papillary thyroid, it's different, it's the one in the medulla, everyone should be tested for RET because there is a high enough incidence of there being a familial condition that testing is warranted. The next hereditary condition are the paragangliomas and pheochromocytomas. There's a very confusing terminology here. Pheochromocytomas specifically refer to tumors of these neuroendocrine cells that occur within the medulla of the adrenal. Paragangliomas refer to tumors of very similar and related cells that occur in other locations along the paraspinal axis or elsewhere in the abdomen or in the chest. And why the pheochromocytomas were separated out as a different group is mostly because of historic reasons. Okay, and then this is a note that up until about 2002, it was assumed that just only 10% of these tumors are hereditary, and in all cases it's associated with a syndrome, either NF1 neurofibromatosis, where you get the bumps on your skin, multiple endocrine neoplasia type 2, where you have thyroid medullary carcinoma, or von Hippel-Lindau. But since 2002, it's been recognized that that's not the case. Actually, about 25 to 35% of patients will have no family history, and they'll have a hereditary mutation that causes a pheochromocytoma or a paraganglioma. And so the result from this is that if you have a paraganglioma or a pheochromocytoma, you should have full genetic evaluation. And there's lots of genes to look at, and it's sort of a complicated situation. But typically, at least in my practice, I'll go through all of these until I tell someone, okay, at this point in time, I don't think it's hereditary, but come back next year and we'll test with the new genes, because there's new genes every year at this point, or close to it. I think management is probably a little bit far afield here, so I'll go through it pretty quickly. I think just because it's relevant to all hereditary conditions, the main point is to stay in touch with your physician, and that you can't walk away from your treatment and being monitored. For my patients, let's say for the hereditary paraganglioma pheochromocytoma, we do an annual visit. FDG or DOTA PETs, functional imaging, is used to look for tumors. I'm thinking mostly about the pre-symptomatic individuals, so that is, they have a mutation, and yet they haven't yet developed a tumor, and this is how they're followed. So functional imaging is used alternatively with anatomical imaging, and then of course you follow the blood test, which is the easiest to do, and that's done every year. And then this is a little bit of evidence about why you do biochemical testing. So if you compare people who were figured out that the family has a mutation and they had biochemical testing versus individuals who didn't know they had a mutation, the size at which the tumor is found is 7.3 versus 3.7 centimeters, so a big difference in tumor size. And what we think is that around 4 centimeters is the cutoff when these particular tumors tend to spread. Then when you add on using imaging to look to see whether or not someone might have a tumor, now we're comparing what's the sensitivity of biochemical screening, which is about 40%, compared to the sensitivity of imaging, so 87%. So this is saying if you come to a clinic and you have a mutation, when you have negative biochemical testing, there's still a residual possibility that's quite substantial that you in fact, without doing imaging testing, that the risk that you have a tumor. So that's why we include both biochemical testing and dedicated imaging for screening. Okay, then this is sort of about the evolution of our knowledge. So historically, people thought that hereditary tumor conditions were 100% penetrant. That means by the time that you're 80 years old, there's a 100% likelihood that you'll develop some manifestation. And this is thinking just specifically about SDHB. Now we think that's more like 30% of people with an SDHB mutation actually develop a tumor of some kind. That's why there are oftentimes families where there's no one who has a history of a tumor, and yet the mutation shows up within that family, because it doesn't always present. And this is partly to do with the second hit idea, which I talked about early on. You're born with one mutation, and you may or may not, throughout the course of your life, get that second hit, and it's sort of chance whether or not you do or don't. And the last part is that if you have a hereditary syndrome, that doesn't mean that it happens when you're young. For SDHB, there are plenty of mutations and disease that arises in your 60s or beyond, so it's very important that you follow up and have continued screening if you do harbor a mutation. And I think this is just the last slide, is a summary slide. In most cases, right now, our general sort of statement is that if you have an isolated carcinoid or even a pancreatic neuroendocrine tumor, you almost certainly don't have MEN1, and you very likely don't have another mutation. I think anytime one of these tumors is diagnosed, it should still trigger an evaluation. This should be considered, whether or not there's a possibility of MEN1 or not, but not necessarily an immediate jump to genetic testing. If you've had previous MEN1 testing, but you have multiple features, I think it's time to ask yourself whether or not the full testing was done. Testing has evolved over the years, so previously deletion analysis, for instance, wasn't done. That may be something that should be included, and then again, there's other genes that act similarly. Last thoughts are that medullary thyroid cancer should always be associated with RET testing. Paragangliomas and PHIOs are frequently hereditary and should also always trigger genetic testing. And then lastly, if we can make a genetic diagnosis, it can inform the management of you and family members and is really important for preventing complications. Usually, it's the first person in the family to get identified that has the most dramatic course, and then once follow-up and screening is instituted, we can prevent a large number of the complications. And it just becomes part of life, but a preventable part of life in terms of complications. And the last thing I wanted to show was just a quick data slide from my lab to follow up on some of the basic research that's been done. In particular, my lab's been trying to model the paragangliomas and pheochromocytomas. We're using mice, and we're finally having some success. Here is looking at the cortex of an adrenal, and this is the medulla. And this is the medulla from one of our genetic models of the tumor syndrome. And so hopefully we can use these guys to learn more about what drives these tumors and figure out specific sensitivities to treatment. So thank you.